Hello. Hopefully, you guys haven't had any issues signing on. I assume by now most of you guys are experts at Zoom, like the rest of us, and you guys are somewhere safe and perhaps at home. So this webinar is one of the few things that has not changed on my schedule since COVID hit, and I think SIIM. We're lucky that SIIM had the foresight to schedule these kind of in this content, in this format. Today we have a great talk for you guys. The topic is the role of AI in the developing world. And that was the original topic. And then we, in the last few weeks, we decided to maybe frame that a little bit in the COVID era, because as everyone knows, COVID has changed basically all industries and has disrupted things sometimes in good ways, sometimes in bad ways. So last year and really the last couple of years, AI was the really hot area. And we had lots of AI companies starting. We had companies kind of developing AI strategies. And that was 2019. And this year, really, COVID is the new AI, right? And so every company is a COVID company. If you're in academia, everyone is a researcher, COVID researcher. But today we're really focused on the topic of AI in the developing world, and maybe how COVID is affecting that, for better or for worse. And we have a line of experts, and I'll go through them right now. Judy Gachoya from Emory University, Murad Gridich from the High Institute of Technology in Morocco, Matt Lundgren from Stanford, and Dan Malora, who is from RAD-AID. So, for me, I'm personally interested in the topic. I think the promise of AI is to deliver better care, and at least more care, given the shortage of providers. And I think that shortage may even be more prevalent during the COVID era. So we're going to get started. And I think Judy is the first speaker. And we look forward to your questions at the end. I think I'm supposed to show maybe one more slide. Okay, so after the presentations, there's going to be a Q&A session. So the last 15, 20 minutes, and be sure to ask your questions through the Q&A icon at the bottom of the Zoom panel. Great. So without further ado,
now, my name is Judy. I am happy to be on this SIIM webinar. I'm an assistant professor at Emory University in radiology and informatics. But more importantly, is sort of and a little bit I'll focus on this in my talk, is that I actually went to medical school in Kenya and practiced in Kenya before moving here. And so I thought, because we'll hear from different views, that my talk should be focused on sort of my experience and what we've learned from really when I started to work in health information systems, not necessarily, actually not AI in global health, and what that can mean for us moving forward. And so these are my disclosures. Really, most of them are more around service to various organizations. I have a grant from the NSF, just sort of looking at how humans and machine can learn together. And I've always had a small consulting company just around global health, but nothing that I'll say here is not in the open source domain or is to try and sell more things. So, I was trying to figure out what's a good picture to start off this talk. And this is actually a place I've gone to, which really actually holds memories. This is a wall near Kibera slums. If you looked earlier on in sort of international news, you saw there was a stampede as people tried to get food. So the slums are always informal settlement. And, you see this guy, just reminds me of my Nairobi hustle. You're walking with your umbrella, being ready for the rain because you have a long way to walk. And, he has a mask. But, like looking at the back here, it's sort of this simplicity that sometimes you can assume that goes on in global health that I think is really special here. And so, number one, you can see we've already said take responsibility, fight COVID as a community. You can see this is sort of like the COVID shape. Instead of groups together, socially distance, hygiene measures, and you can see hand washing and a mask. And really, there's no language, but by just looking at this picture, all of us can come to a shared understanding. And so what's important, and sort of my very first years of medical school, we were dealing with a different pandemic, and this was the HIV/AIDS pandemic. These were pictures of what we would see outside the hospitals where I went to school. And these hospitals inspired people to come together, and once they came together, led to amazing things. So one of the first things, which is how I got involved in medical IT, is an open source medical record system that initially started as an Excel and Access system. And this was important for me because at this point, we were really not teaching people about, like EMR. We were teaching them how to work with computers, securing computers, thinking about power. And so you needed to come in with a broad set of skills to be able to tackle a solution. But the impetus for this was that we had so many patients that we didn't know what their medications were and what sort of like the outcomes were. And so in an effort to do this, physicians who love informatics came together and formed one of the most successful open source medical record system, now used in 3,000 sites with over 8.6 million patients. And so throughout school, I did not go to West Africa, but this is one of my classmates. And, in 2015, he had volunteered his time, and actually a couple of my classmates spent time in West Africa during Ebola. And this was also a terrible time in terms of pandemics, but I got involved a little bit on the software side. And because you can imagine, if you have to wear PPE, all these counts, you're in sub-Saharan Africa, it's hot. And so what happened was that this innovation came to be a very, very small system that could be charged. Really, if you had a portable car, you could just put it in the USB dongle and would have a server for a month. And then these cases around tablets helped that you could just work with them with very good responsiveness on the touchpad, and then just dip it in chlorine for sterilization and then move on to another patient. And so all this system really was powered through an Excel spreadsheet at the end of the crisis, making it easy to sort of scale up technology in response to a crisis. And so I really find myself thinking around this COVID, and just generally as a physician, also as an immigrant and someone who's really 99% of the family lives in Kenya, that this idea of Ubuntu, because I am because we are. And if you look at successful technologies, and we had lots of mistakes, and it's not going to be enough for me to go through them, is that usually the first one, there's always, and we've studied this by just looking at open source communities, is that the first one always starts around a problem. And the people who are those leaders are very good people at sort of problem-based leadership. They invite and they inspire people to come together and tackle a problem. And then you grow through a community, and most of the other stuff, you can see you mature through governance, and in phase 4, if you don't manage things well, then you can have competing interests. And so if I come sort of back home and to think about this crisis, in 2010, these were my teachers and and actually I was just done with medical school here. And by this point, we had achieved almost 97% of household testing for HIV in Western Kenya. And this took a span of June 2007 and June 2009, and was facilitated with mobile phones. And I worked on this a lot, but also required a lot of community partnerships and community entry that you can imagine. Countries that can scale door-to-door testing are actually now in sub-Saharan Africa, and provide an impetus for us in North America to learn from. And during this time, we saw some need for us to speak a common language, because we speak many languages, and evolved to an interface terminology dictionary. So most of these systems that are deployed in place if you have to work with them, already have very standardized way of collecting data. They may be on mobile phone or forms that are subsequently entered on computers. And with actually one of the largest maintained terminology, which has 16 language translations of today, and is actually populated now to have the COVID data. And so when I think about this and I think, well, I'm going to deploy an AI solution, and what have I learned is these complexities of capacity. You see, most of the papers and publications will be, you know, shortage of experts, shortage the gap between doctors at different levels, and you know, obviously we know the AI is better than ABCD, and you know, I think you have to think about complexity of capacity in a different way. If you think about the health workforce of Africa, it's going to be the largest in a couple of years, and what that means is that if you're trying to replace these people who will need to scale up and enlarge, and you take away a training opportunity for them, then you're actually doing more harm in the long run. And so your strategy has to think, what am I going to do, and how do I involve sort of participatory design and deployment of your AI solution? And this poor fragmented infrastructure, and I'm pretty sure we'll see many speakers through this talk about this, is a highly contextual problem to solve. So I give this example of my own parents. When they're sick, if they're very, very sick and they went to Nairobi, they will go to Nairobi to Kenyatta Hospital. But when they are in my village, they go to a local hospital. And so the records that I see are usually in a handbook, and the records are fragmented. And so if you're going to sort of scale something or implement something that does good and streams down to every user, then you cannot approach this as a one size fits all. And so you can imagine some of the earliest things that we did were to deploy immunization information, and those were really disseminated on forums like Facebook, which today, if you think about global health, that's very, very controversial because we know of the anti-vaccine movement. And so the lack of clear and uniform guidelines for specific diseases sometimes can be used to perpetuate harm, as was noticed earlier on in the HIV pandemic, where people, even if they knew that triple therapy was effective for prevention of mother-to-child transmission, continued to give single-dose ARVs to see what was the rate of transmission in developing countries where that was the standard of care. And so just because these places may not have clear guidelines, you yourself, especially if you're from somewhere with clear guidelines, you need to hold yourself to that standard, if not higher. And so moving back to sort of the AI stuff, you know, we recently wrote an editorial, really some of my radiology AI trainee editorial board trainees, you know, thought this was a good sort of debate and discussion. And some of the issues that we raised were, could trajectory of early imaging predict the hospital cost? And I will sort of put this in the context of developing countries. And could radiology biomarkers correlate to immunology response? And could we start to see AI drive a personalized drug choice through prediction of the treatment response? But when I think about this is a track I worked on from around 2016. This track has been there. There are 2 tracks like this in Western Kenya. And this track has a mobile X-ray system and has actually been running AI through a partnership through NLM. It's not really used for clinical work, it's used for validation and research. And still a radiologist has to look at this imaging, and still the partnership is not yet implemented. And of almost the 130,000 HIV patients who were in our cohort have a form of a chest X-ray. And you can see with time, what happened was that we started to deploy the gene expert. And if you've been following sort of like the new imaging, new testing strategies, gene expert is going to play a big role. And you can imagine that when you think of deploying your AI system, you have to think about the context that you're working in and sort of embed yourself in those systems. And so your standard workflows for sure will fail. And so there's a big problem also of information and misinformation, and you know what the WHO director calls an infodemic. This is a simplified view of the map of Africa, which shows many, many languages that are spoken in the continent. In Kenya, in my home, we have 52 languages spoken. And you can think that AI would have a big role, not just thinking of X-rays and reading them, but sort of translating and fighting the misinformation and providing the correct information at edge, because no human being can scale that way. And so I find myself back to thinking, what are we as a community going to do to help, to work with, because we learn a lot from reverse innovation, and we sort of are part of this community in the era of COVID. And so one of the things that I didn't mention is that when I started on the healthcare systems, it wasn't really that we were capturing how many people had a cough. That was not the most important question. We asked, how did you come to the hospital? Did you use a bicycle? Did you use public transport? And so in a different way, we've captured these social determinants for health that we know have an important role in COVID in mobile form. And now we have AI that can help us start to do data amalgamation for scale to really figure out outcomes in a way that we haven't done before. And we know that most of the AI systems will be at the edge. And so as our team here, we are involved in an open source project and part of some of code that we are trying to deploy low powered models and figure out how their performance sustains as they go to low powered devices, because that's how we make them useful. And so thank you, and I look forward to discussion.
Great, thanks a lot, Judy. I never knew what Ubuntu meant. I've been using Ubuntu Linux for about 10 years now. So next we have Matt Lundgren. So thanks, Matt. We're a little bit behind schedule already, Matt, so might want to just keep it at like 9 minutes or so. Thanks.
Hi, thanks, George. Okay, let me pull this up. All right, so thanks everybody. Thanks for having me here. Thanks for being attentive here. This is going to be a quick talk about an open source platform for scaled deployments, and Judy touched on some of this concept already, so it'll be a nice lead into what I'm going to talk about. These are my disclosures. So I'm coming from Stanford, but I am just representing really what is a humongous group of researchers, both computer scientists and faculty in the medical school, and then many industry and other academic institution partners who really contribute to all of the things that I'm going to be talking about today. And as part of that, we've done quite a few different research projects spanning different areas of medical imaging. We've definitely made a point of making sure that our data sets are made available to the research and education community so that our work can be replicated and even improved upon, which is sort of the whole point of what we're up to. But I think when I look at some of the justifications for the things that we do, we know that there's opportunity for improvement in the radiology workflows and the things that we do. We know that some of the errors, or many of the errors that occur in medicine, can cause harm, and some of those related to radiology. But I think from our perspective, we think a lot about how there's an enormous disparity in access to some of the radiology expertise that really underpins a lot of the things that we do in medicine, particularly now. And so we believe that this is an opportunity with some of these technologies to democratize this knowledge. We're not the only ones who do this, right? This is just a small sampling of some of the companies, although some of these may not be around anymore, but there's a bunch of companies out there that are all working on similar ideas. And this is great. They have very bold mission statements that they want to transform healthcare for the world, and they want to provide humanity with these wonderful systems. And I applaud that, and I think that's great. And when we look at what we mean by the world, we can sort of take this chart, which tells us where most of the people in the world happen to live. And we see, North America kind of way over there to the right. But then when we look at this chart, we actually see where the money is spent. And all of a sudden you see some of the North American countries kind of popping up to the top. And I think that this is actually the chart that a lot of these companies and groups are looking at, not this one. And that's one of the criticisms that we have for some of the approaches, because when we look at where we can have the biggest impact, we look at places in the world that don't have the radiologic expertise to perform routine medical care. And we recognize that that happens in a lot of places that aren't spending the kind of money that we're seeing per capita. And so, you know, when we talk about how do we get some of these technologies to the largest populations possible in a way that allows for sort of homegrown research to occur, or trials to spring up from different places without us having to sort of push it through a top-down approach, we think about the cell phone as the platform. And Judy touched upon this. This is one of the most ubiquitous devices on the planet, and it's thought that more people have access to smartphones than to clean water. And we know that this platform has become both cost-effective and incredibly powerful. And we recognize its potential for its use in medical imaging. But this isn't just a global health discussion. This is actually part of routine care. This is a really great paper that I love to show the data from. This is a survey through the NHS where they ask clinicians, you know, who's using smartphones to just go about their daily life to you know, help get consults and take pictures of images and ask their friends. And half of doctors say that that's what they're doing routinely in their practice. They're taking a picture of something, maybe it's a rash or maybe it's a chest X-ray, and they're texting it to their colleagues and saying, "Hey, what do you think of this? What do you think this is?" And you know, the criticism that I've also heard about this idea, particularly amongst radiologists, is that, well, you can't make high quality diagnoses with smartphone pictures. And so this is actually a paper that sort of starts to refute that, where they looked at a WhatsApp text picture that was taken with a smartphone, and they compared the diagnostic performance of a WhatsApp snapshot of a chest X-ray with an actual workstation with a dark room and everyone being quiet and all that kind of stuff. And they found that it's practically the same. And this is important, right? Because these are for clinically significant findings, which is exactly what we care about. If you can imagine that the performance can be just as good with a WhatsApp text, maybe we have opportunities here for doing the same with some of these platforms. And so that's what I'd like to sort of mention. Now, we have lots of students who are more than willing to help us generate data for taking pictures of X-rays. This is one of our fearless grad students who's, you know, currently obviously using his education to the top of its ability, taking cell phone pictures of X-rays. He does a lot more than that, but this is just something to mention. But what we found fairly quickly is that machines don't like artifacts. And artifacts come up all the time when you take pictures of either screens on the left, which is an example of a moire artifact, which is that wavy line, or on the right, you see some glare. These are the things that happen when you're taking pictures of film. Those are not problems for humans to read through. I mean, those don't bother me. I can still look for an effusion and I can still look for pneumonia, but it does bother some of these algorithms that tend to be relatively brittle and not robust to some of these outer distribution perturbations. And so what we've tried to do, and what we've successfully done now, is we spend a lot of time creating data to train our models to be robust and essentially ignore some of these artifacts. And these are some of the examples of ways that we've caused some of the perturbations in the imaging data sets that we have. And again, we focus a lot on glare and the moire artifact because those are the things that tend to come up the most. There's a lot of research around this in other domains, but this is something that we've spent a lot of time on because we recognize that if you're going to translate some of the advancements that we've made through the smartphone, through the most democratized ability possible, we think that this is going to be one of the keys to making those models work. Again, we spent a lot of time on this. We have a publication coming out. We hope to have this model ready as well. But we've gotten to a place where we're starting to see the performance line back up to the original model on the original images and not have being disturbed by the artifacts. And that's really been one of the key achievements of some of the work that we're doing. But what I wanted to really talk about, and hopefully we can translate this over to the panel, is the idea that we need a platform beyond just a smartphone to responsibly and most importantly, ethically get this into hospitals for clinical trials, because we don't want to be in a position where there's just a Wild West open source approach. We really would like to find a way to organize, but also deploy this in a way that avoids some of the privacy issues to allow us to study this on a scaled approach. And so we've turned to the REDCap Consortium. This is a phenomenal enterprise. It's actually been around for a long time in response to some of the commercial vendors who were around in the early 2000s that were not meeting all the needs and charging a lot for clinical trials, particularly in other countries. And this was initially funded by the NIH. There are 700, 800,000 users or projects from all over the world. And all of these projects are already embedded into hospital systems. They've passed some of the privacy laws for the local institutions and allows us to have a place to scale what we're up to. They also have a mobile phone app, which is really terrific because if we're planning to run an open source free AI model as part of a clinical trial, and we're going to use cell phones as our delivery platform, this gives us a really great opportunity to do so. For those of you who are familiar with some of the nuances of PyTorch and TensorFlow and some of the conversions there are definitely development aspects of this that's going to take some time. And part of that is getting our PyTorch code over into TensorFlow.js, which really allows us to deploy this in an environment that makes it extremely seamless on the smartphone. But we have gotten to a place now where we've worked with the Red Cat folks and we're about ready to present this, where we can do real-time on-device analysis with one of our models. We can do inferencing on any image that the camera phone takes. Because the person or group is using a Red Cap instance through their hospital, there isn't a privacy issue. There isn't a potential for data leakage in that sense. It actually has a scalable HIPAA-compliant backend, which really helps us because, again, some of those infrastructure costs are significant. And then finally, again, it works on any browser, any mobile phone. So, whether you have the latest iPhone or, an Android from back in the day, it will work on that platform. It's a very lightweight approach. So this is one of the ways that we hope to push out just a pilot of how can we get some of these clinical trials up and running in a large scale for a relatively straightforward model, such as for chest X-ray diagnosis, in a way that allows us to really get a sense of how these things might perform on a platform like the smartphone. So we envision the trial looking more like we're going to have this in the hands of primary care doctors because there aren't often radiologists around. So very similar to that, a clinician will see someone for an abnormality. They will take a picture of the X-ray, and then they'll have an analysis and make a decision clinically on the device, right? So this is just like as if they texted a WhatsApp to their colleague and said, hey, do you think this is pneumonia? Because I really want to treat this guy and get on with my day. This is generally how we imagine the workflow might go here. And we have a trial here at Stanford on that exact concept with primary care docs and nurse practitioners, and we look forward to sort of rolling that out soon. This is just an example of my team. So clearly lots of folks involved in this project, a lot of people interested in the work that we're doing. Thank you, and hopefully I didn't run over time. Thanks, George.
Matt, thank you. That was wonderful. I never knew that WhatsApp or really Facebook is the largest competitor to our radiology tax vendors, right? And so very fascinating. So great. So next on our list is Dan Malora, who's the president and CEO of RAD-AID.
Hi, everyone. I'm Dan Malora, the CEO of RAD-AID, and thanks all for coming together today, and thank you, SIIM, for inviting me. So I'm going to be giving you a talk about AI's role in global health from the perspective of RAD-AID. So what is RAD-AID? So let's start with that. So it's a nonprofit public charity. We were founded in 2008. And our main role is to build radiology capacity through education, equipment, and support. We have over about 13,000 volunteers and supporters. We're an advisor in official relations to the World Health Organization, and we're in about 35 countries and 81 hospitals. So the purpose of starting with that is that our purpose here is to bring AI into low resource regions with the effort to help people. And also to build that capacity to increase radiology services. So here's the footprint we see throughout the world that we work in. So I get to be the talking head for this presentation, but it really reflects the work of RAD-AID's management team and the many volunteers that go into this. Now, COVID-19 isn't the first outbreak that RAD-AID has seen in its history. So we've been through H1N1, we've been through MERS, 2 rounds of Ebola, and we've seen Zika. So there's lots of issues with outbreaks all the time that affect RAD-AID's work. But this, of course, is one of the most profound impacts. So we have to start off with the assumption or the question really, how can AI positively impact low and middle income countries? You've seen this list before: image interpretation, work list triage, image quality, patient referrals, dose reduction and safety, and population-based registries. So you've all seen this kind of approach that says, okay, these are the positives that AI can potentially bring to low-income countries. Here's an article that I encourage you to read that was published in Science. This was before COVID-19. That gets into the same things and talks about, for example, how physicians could do image interpretation, equipment for enhanced troubleshooting, or even epidemics you see down here in this chart. So the point here is that this was written before COVID-19, and we were already talking about AI being aimed at these types of applications. So now we have to ask ourselves, well, why can AI actually have any positive role for low and middle income countries specifically? And that gets into the issues of shortages, shortages of radiologists, technologists, equipment, infrastructure. So the overlying hypothesis here is that AI will improve healthcare for resource settings by overcoming the need for these other scarce or absent inputs. So if you look at the public literature, in this case, it's The Economist, and looking at, so for example, this is directed at the business community and economic community. It says AI, radiology, and the future of work. So already in the public mindset, radiology is the forefront of AI in the healthcare space. And then it mentions clever machines will make workers more productive more often than they will replace them. So this is the emphasis here, is the word productive. And so when we have this conversation about AI, we have to ask ourselves, well, what does that mean? So for productivity, from an economics point of view, you're asking yourself, how much output do you get for a unit of input, essentially? So per unit cost, and it breaks down into labor and technology. So for labor, it's people and knowledge, and that knowledge is going to come from a baseline knowledge plus how much training you get. And then in the technology side, you're talking about the tool and the infrastructure. And from the infrastructure standpoint, you're talking about regulatory and the physical infrastructure, like things like computers and electricity. So the reason why this is so important to RAD-AID is that our radiology readiness assessment really raises the question of how a place is ready for AI to be there so that that productivity gain can occur. And that means knowing what's already there. How do you fill the gaps in to get a low resource hospital to its goals? And that means knowing how you can put AI into a place by knowing what's already there to capitalize from. So let's look at the labor side. So this is the productivity argument for AI, right? So here's labor, and then let's talk about people and knowledge. Well, what are those people really supposed to do if there's AI? So one is that they're supposed to supervise AI implementation, interpret the AI outputs. So if there's no one there to interpret an AI output, say an AI algorithm says that there's a malignancy, who's going to be there to interpret whether to trust that result? If you have validation, which comes from the idea that maybe the AI was created in a different region, culture, or high income setting, who's going to do the local validation to know that that AI is still useful in a low resource region? Then there's the generalizability of the results, right? So we don't know sometimes if an algorithm will generalize to populations outside of where the training set came from. And that essentially comes down to the trustworthiness of the AI results. So this is the roles for personnel. Well, let's look at some scenarios for personnel. Let's look at Tanzania, where RAD-AID has a very active program. So for in Tanzania, radiologists, there's one radiologist per 1 million people. And in the US, on the other hand, it's 1 per 10,000. So this is about 100-fold difference in access to radiology. And I'm thankful to Anne-Marie Lugasi for this data and her leadership of RAD-AID Tanzania. Here's the technologist side. 1 technologist per 140,000 people versus 1 per 1,700. So these photos come from RAD-AID Tanzania in the early part of this year, before we had the real onset of the COVID-19 outbreak. And you can see here we are just supporting personnel, just as I said, on that productivity side. But here's what we look like now. RAD-AID is still supporting personnel, but we're having to do it with a lot more PPE. We teamed up with VRAD for educational resources. Here's a PPE distribution program in Malawi. And then here's a Zoom session with Guyana in training the residents who you can see here in Georgetown Public Hospital. So the point here is that it hasn't changed. We just have to change how we're approaching, but the actual strategy of teaching people radiology and the necessary skills that underpin AI is still relevant. Same goes for interventional radiology. Here you see several pictures from Kenya with our IR teams previously teaching, even using a Mentis simulator unit. But again, this doesn't change just because of COVID-19. We may have to change the approach, but still the use of a simulator unit could be very advantageous through remote work. So now let's look at the other side of it, the infrastructure side. And we have to think about this picture here from Nigeria, University College Hospital. So this is what it looked like in September 2019 before RAD-AID started its work there. And you can see that they're still using film jackets. Here's RAD-AID Ghana program in Korlebu Teaching Hospital, and this is the scenario that we found in 2012. But this is the impact of moving infrastructure into low resource regions. It's really important for AI. So you see a total transformation in how this is possible. And you see how our donation of packs in these locations, for example, with support from Amber Health and Watson Health Imaging and others, we've been able to put in this kind of infrastructure. And here's what you see as a transformation of a reading room in RAD-AID Guyana. And this is the kind of infrastructure also that we've been putting in place where cloud integrates with a local small low footprint box for running packs for local modalities, but also having a cloud backup. Now we have a program in place with SIIM called the Global Ambassadors Program. And these are the amazing people that have contributed to this because this is a way for this infrastructure to be in place. And I would encourage all of you to look at the Global Ambassadors Program as a way to participate in that. So when we look at readiness for AI in terms of CT infrastructure, I mean, this is a wonderful CT image of the coronavirus affecting the lungs. But the problem is, what good is AI for CT if a place doesn't have any CT? So if you look at low-income countries that have 1.7 million people per CT scanner, there really is no impact if you have AI for CT versus a place that has 25,000 people per CT scanner. So this is one of the factors that we have to consider, and some of the other speakers on the panel have addressed that. But RAD-AID has been working on CT implementation. So you see us pushing in a CT unit into a hospital in Guyana, and here we are 3 years later with a fully trained technical service. So if there's one slide for all of you to remember is that this is RAD-AID's approach right here on this slide for improving AI's impact on productivity. I talked about education, and here's the infrastructure implementation, and then a phased AI introduction. Now notice I don't say phased, I don't say AI rollout, because what we have to do is engage the local stakeholders and then empower them to do their own phased and staged rollout of their own AI for their own applications. So for example, here's an approach that we've taken. Here's clinical trainings going on in Guyana, basically doing clinical breast exam trainings, but also have ultrasound, mammography, and this is the KIOS breast imaging ultrasound support system. So by integrating all of these, we can hit all sides of how AI can best impact a low resource hospital. Now here's a configuration, look at this. I mean, here's the scanner sending images to a PACS gateway and then to a cloud and then to a processing center. Again, this is with the KIOS system as an example. We're doing this in Peru, Kenya, and Guyana, but notice how complex these data workflows are. We have to address, where is this data going and what's the best configuration to make an impact. So now we have to talk about the regulatory side of what this infrastructure argument is for productivity. And here comes the data rights, flows, and responsibilities. So I'll be doing a second lecture with Judy for SIIM on ethics of AI. So I'll get more into details then. But we have to ask ourselves, where's the data moved and stored? How is confidentiality and privacy protected? Who anonymizes the data? Can new AI be created from low and middle income countries' data? And then what's the fair pricing that occurs if AI then is sold back to the original source country? So for example, the UN Conference on Trade and Development made this warning in the Digital Economy Report, warns that developing countries risk becoming mere providers of raw data while having to pay for the digital intelligence generated using their data. Well, this is a form of kind of neo-colonialism, right? A low-income country will produce something based on a raw material and then have to pay extra for the high-end product that comes from those raw materials. Well, what's the evidence for that? Well, if you look at the regional sources of these publications, most of it's coming from the high-income countries. If you look here, the valuations of the cloud providers are mostly very high-valued enterprise cloud companies that are based in East Asia, Europe, and North America. So you see very little participation in the economy of cloud here at this level. And then when you look at some of the cloud traffic, again, you see this very thin sliver that's coming from the cloud traffic of low and middle income countries. So part of RAD-AID's goal here is really to create a fair and level playing field for this economic and technological balance. The fairness via policy is really quite critical for that. Now, there's also a shifting metric for imaging in low and middle income countries, and I think COVID-19 has really shown us this. Most of the AI research focuses on the receiver operator curve, the area under the curve, focusing on sensitivity and specificity. But a better metric is positive predictive value because it does take into account differences in prevalence. Well, why is this so important? Well, some diseases of high prevalence in low-income countries, such as TB, will have a different usefulness for imaging than something that has a low prevalence. Well, COVID-19 has a wide range of prevalence, as you can see from the map. And that's why we've seen a very different use of imaging and use of resources when it comes to COVID-19. And therefore, AI will potentially play a very different role. So for example, in many low-income countries, what they're doing is they're telling people not to come to the hospital and to stay at home as much as they can because the hospitals themselves don't have ICUs and ventilator units. On top of that, if a patient does have it in a low-income country, they may be actually sent to a hospital that's called a COVID center. So that's a very different pattern than, for example, what we're seeing here in the US, where there's a very high prevalence, and we may have a very different consideration of how imaging would then be used. So any AI application that comes from a high-income country but doesn't take into consideration this heterogeneity of impact really is missing the mark, and we have to account for that as AI continues to develop. So here's the basic summary. You know, the argument for AI comes down to productivity, increasing the output for each healthcare worker in terms of labor and technology. If we look at that labor and technology, what we're really trying to do at RAD-AID is first support clinical education and IT education, because we have to empower local personnel to know how to supervise those inputs, implement the structure, and manage it. And then we have the infrastructure itself, and then a phased AI introduction that then makes it all possible to put it together. So thanks for listening.
Thanks, Dan. Thanks for that great session. And there is another session, the SIIM 2020 annual meeting on ethics of AI that Dan mentioned, and Judy will also be on that session. It's June 25th at 1:15 p.m. And so you guys can join that if you want to learn more. And so now we have our final speaker, Dr. Grdic from Morocco.
Thanks, Charles. Hi, everyone. So I am Morad Grdic from the High Institute of Technology in Morocco, in North Africa. So thanks first for inviting me to talk in this webinar. And yeah, so I'm gonna start by my talk by giving you some useful statistics where I will highlight about how many people one physician will treat in different regions. So Morocco, Africa, USA, and European Union. So if we can see, for example, in Morocco in 2017, we had one physician for 1,429 people. And in overall Africa, it is worse. So it's just one physician for 5,000 people. And if we compare that with USA, we can see that in US, we have one physician for 385 people. And more importantly, this goes better in European Union by having one physician for 378 people. So from this statistic, we can see that healthcare is really a real issue in developing country, taking an example here, Africa and as a continent and Morocco as a country. Okay, so since I'm coming from developing country, I'm gonna highlight some two projects I have been involved in. So Deep Africa first. So Deep Africa is a startup I founded 2 years ago, where we were using actually deep learning algorithm to diagnose breast cancer. And I'm gonna highlight some issues we had back then. So first we talked to some pathologists and radiologists, and what we found actually that most of them they are not really aware about these AI technologies and these deep learning systems. I know, I mean, because they are busy with they have a lot of patients to treat and so on. So also we have difficulties to collect data. We need mammograms images and histopathological images, and we had real issues to collect these images from local hospitals. And also something very important I want to highlight here is the investment. So since we were a startup, so we had a real issue to convince investors to invest in AI technology and help the healthcare community in Morocco. And also we had a lot of problems to collaborate with local hospitals. This is including public and private hospitals. So as a result, we quit the idea. Okay, so the second project I want to highlight is the COVID-19. So I'm gonna start by talking about some useful information. So in Morocco, the first positive patient that was diagnosed with COVID-19 was on March 3rd. And from March 3rd to April 20th, around 7 weeks, in the overall country, in Morocco, we had just 2 centers to test COVID-19. And these 2 centers, they were located in Rabat, capital city, and Casablanca, the biggest city in Morocco. And it's like in the north. And if you live, for example, in the south of Morocco, you have to wait like from 2 to 3 days before you can receive your final test, which is really bad. And back then we have just 500 tests per day, because they say it was too expensive for the Ministry of Health. So I come up with just a very simple project idea. My goal was to collect COVID-19 CT images from local hospitals here. And the goal is to have a data set for further AI use. I know this is still ongoing debate. I mean, how AI could help to diagnose COVID-19 using CT images, but at least we will have our own data set what we can work on for research and share them with other colleagues in other countries. And again, we really face a lot of problems to collect these data sets. We talked to some radiologists. We didn't get really positive feedback. And also we wrote to the Ministry of Health in Morocco. And until now, they didn't give any positive feedback about our request. Okay, so what to do? We come up with an idea with some of my students. We built a chatbot in Moroccan dialect and in Amazigh. So here we speak Moroccan dialect. It's kind of Arabic dialect, and also another language called Amazigh. And the chatbot, the goal of chatbot is to answer Moroccans about COVID-19. So something like symptoms, something like what is this COVID-19. Also give some useful statistic about how many, for example, new cases in Morocco or in different regions of Morocco or other countries in the world. And we had a couple of hundreds of questions to the bot, and yeah, so we were happy about this project. Okay, so I'm going to highlight some issues, actually healthcare issues in development work, since I'm living in Morocco. So as cited before, we have in Africa, we have one physician for 5,000 people. That's the real problem. I mean, that we have to solve. And also something very important is the lack of what I call lack of infrastructure. So machines here like CT scanners and others, they are old, or if local hospitals they buy new ones, we have a lack of expertise. There are no experts actually to use these new machines. So I talked to some hospitals here in Agadir, where I'm living now, and they say they had machines like in two years now, they didn't use them because of this problem. And in 2017, the WHO came up with the statistics in Africa, saying that 3/4 of machines are out of order. And something we want also which is an issue actually, is this lack of collaboration between medical doctors, clinic, AI scientists, and computer scientists. We don't have labs that actually they can gather these researchers, so they can help each other and work on specific projects. Also, most of the diagnosis is carried out manually, and sometimes in some specific disease like cancer, for example, you can wait for several months before you can receive your final test, which is really bad. Okay, so AI in healthcare, what's next? How AI could help, I mean, the healthcare in development works. So as AI community, I think we did a lot of cool applications in different fields. So in NLP, we did cool work in machine translation, image classification, self-driving car. But I think in healthcare, we have much to do actually. So something very important I want to highlight here is product deployment. So you can build an AI system or deep learning system in medical imaging, for example. You can get state-of-the-art, beat all the previous systems. But when you want to deploy this system actually in clinics or hospitals, you will face a lot of problems. And I'm highlighting here a new paper just came last month by Beat and collaborators from Google. They build actually in a deep learning system, and they wanted to deploy it in 11 clinics in Thailand, and they face a lot of problems. So I think we have to think about this problem actually in the near future. So I think what we think also is build what I will call here robust AI systems. So what I mean by robust AI system first is that AI system that can learn from small data sets. We know that actually radiologists, they don't have time to label images and so on. So I think we should think about it seriously. And we already start working on that. A lot of researchers start working on that. And also the infrastructure. I think if we build the system, AI system that works in John Hopkins, I don't know, hospital, it's the same. It should work in. I mean, the images coming from another CT scanner in Africa should also treat the same, which is very interesting. Okay, so finally, there are some. I will highlight some AI solutions actually in the how AI can help in development work. So I think it could help the medical doctors to treat more patients, trained, less qualified medical doctors as well. We can also, it has an impact to reduce the time spent on repetitive tasks, and the saved time can be spent looking after patients, making decision about treatment, and also finally doing and contribute to scientific research. And also there is a cost associated with this time saving. So as a conclusion, I think here we have to think about something very important. We have to build lab, what I call multidisciplinary research, lab that can gather medical doctors, AI scientists, business professionals, product development. So something like Stanford AI medical imaging lab, where they have all these these researchers. And also, we have to help the developing countries to get and use these AI technologies. So it could be through collaborations, through training, something like schools, summer schools, or winter schools. We have just one in Africa called Indaba, and we hope to see more in near future. So finally, my last word, I think we have to to talk about not to talk about AI versus radiology. I think, in my opinion, we have to think about AI plus radiology to help and improve the human healthcare. And thank you very much.
Great, thank you, Murad, for a great talk. So we're going to switch right over to questions, and if you're in the audience, please start asking your questions in the QA box at the bottom. I'm just going to share my screen and kick off the question and answer, but we'll probably try to get you to yours. If we go beyond 2, I think I have to go, but Judy has graciously accepted to moderate some of the questions beyond that. And I just wanted to kick it off with these questions. What is the role of AI in the COVID era? You know, has the role of AI changed? Is there any additional consideration? Is it going to accelerate or slow the need for AI? And then, you know, what about COVID AI? Are there any relevant work in terms of gathering data or models? And really, what can the US learn from lower middle income countries, since during a pandemic, the whole world is constrained in terms of resources? And I know Matt has to leave early, so I wanted to ask him first. Matt, are there any ongoing initiatives around COVID AI, around the data or the models that you are involved with? Oh, Matt, did Matt leave? Matt jumped off.
Yeah,
okay.
I think so.
Okay. So I thought he was on until 2. All right. So maybe we'll move on to the next one. So what can the U.S. or other parts of the world learn from, you know, LMICs in terms of, you know, being resource constrained? I don't know if Judy or Dan, you want to take that. Are there any lessons that we can learn from what you guys know about? And obviously Murad.
Well, to get into some of the questions you've raised here, George, which are all great, you know, has the role of AI changed? I mean, I would say the role of AI has not changed. It's still designed to improve the productivity side, as I said in the presentation I gave. That'll persist within the COVID pandemic and beyond. And then we have to consider, you know, what these infrastructure and personnel issues are going to be. But when you say what can the U.S. learn from the LMICs, I mean, what we're seeing is that anything that is created in a high-income country with the automatic assumption that it's going to deploy the same in a low-resource environment is just false. It doesn't work really that way. And what we're learning from this, and that paper I showed on the positive predictive value and the role for imaging, taking into account differences in prevalence, I mean, that's one of the great learning points of the pandemic, is that the heterogeneity is often what drives these solutions needing to come from the local environment.
Great, thanks, Dan. Any comments, Murad or Judy? I do want to show, before I leave, I do want to show a slide up about getting CE credits, but if Murad or Judy have quick comments about what Dan just said. No, neither one. Okay. So I think we can probably, Judy, do you have a question? You just popped on, or a comment?
No.
So I think we can maybe start taking questions, and I'm gonna let Judy do that because I do have to run it too. But
you wanna show the C slide so that anyone who needs C knows how to get it?
Exactly. Let's see. So before we get to that, next month, there's another webinar, Federated Learning, June 16th at 1 p.m. It's going to be a great session. And then in terms of the CE credits, Here's the information. I think you do have to fill out a survey, but then after that, you'll get your credits. Great. So I'm going to stop sharing my screen, and Judy, you'll take over from here?
Yes.
Great. Thank you, guys.
Thank you, George, for organizing and hosting. Yes, Corey, I think the survey will be available. You can leave. I know it's 2 p.m., so please feel free to jump off. A few sort of questions. I'd like to recognize Dr. Nora, who is actually Kenyan like me, and she has not only questions, but also has some comments in the sort of like what's going on. And she says she's a radiologist in a city hospital in the capital city. And this is a special topic because companies are trying to sell AI to the government, claiming it can replace radiologists. As someone who's a radiologist and does a lot of AI things, I can tell you that AI is not ready to replace a radiologist, but I would maybe want to hear strategies for sort of policy and navigation to prevent such activities. I don't know, Murad, do you have a comment to this?
Yeah, I think the best way to see things now is not to talk about AI versus radiology. I think we have to think about AI and radiology actually to help human healthcare. I think we are far from talking about we'll stop train radiologists, as Jeff Hinton said, I think a few years ago. I think the best way is to see that this AI system, especially these deep learning systems, can help also radiologists. So I'm talking about, for example, in Africa, since I'm coming from African country, we have in some countries more than 1 million radiologists. So one radiologist cannot, for example, take in all these images and diagnose and so on. So if for example, he or she has an AI system that can help him or her to diagnose, I don't know, hundreds of these images, it's gonna be great, and it can help a lot the community.
Okay.
Yeah.
And I just want to say that because we have to be respectful of everyone's time, we're not going to go beyond 2:10, but please keep asking the questions, and I'll pass them around to the panelists and make sure that as long as you registered for the webinar that you get the responses via email. And so there's a question from Hussein. How do you implement AI smoothly in the healthcare systems when you have lack of computer technology of healthcare professionals and they're not properly trained and may not have the resources to use them?
Well, you know, we've been taking the approach of then first training people to use those computer technologies, because that infrastructure and personnel training element should come first before trying to jump to AI. So that's why we're arguing for a model that really has that three-pronged approach I showed in the presentation, because we've seen it very often that an AI software that can be just thrown into a context without really thinking about, well, what other resources are there to use it, then ends up being a waste. So how can that be done? Well, first of all, it's through basic computer workstations, implementations. It could be through online webinars to train people on how to use certain applications. RAD-AID has done on-site workshops as well, such as in Tanzania and Ghana. So as a result, we can have different layers of this kind of implementation so that the training occurs at all levels for that kind of AI and IT personnel.
Okay. There's a very good question from Patricia, who brings up a big issue here that we haven't talked about, which is given the significant global shortage of physicians and radiologists in low resource communities, and that nurses make the greatest percentage of the world's healthcare workers, how do you see being able to utilize nursing in the application of AI in global health?
Yeah, so thank you, Patty, for that question. She's not a plant because she's the director of RAD-AID nursing, so she has a good reason to bring up this question, and I even showed a picture of Patty in my presentation. Empowering the nurses is a really important part of AI and any radiology advocacy and capacity building. So nurses will be part of that workflow. So for example, in a slide I showed about the role of AI in safety and patient management, triage, all of that, for example, would be at the nursing level, where the patient is being handled at the scanner and then triage for further workup. And then who's going to interpret AI outputs if a decision is then going to be made that impacts the care of that patient. That could all be within the domain of nursing. We're seeing a lot of AI also in ultrasound, in obstetrics for maternal infant care. So again, that AI would be directed at nursing. So I think there's a really important role for nursing to play. That's why RAD-AID Nursing is part of RAD-AID's management team, and Patty's done such a great job in leading our program for that, because it is vital, I think, to the strategy.
Awesome. There are a few questions directed to you, Dan, and I'm just going to have Anna sort of forward to you. One is how to volunteer to help RAD-AID, and so the question from Mohammed, who is a part of medical student, global radiology scholar, is wondering how RAD-AID deals with challenges surrounding patient privacy and data confidentiality when it comes to integrating AI in low and middle income countries. And I mean, if it's okay, Mohammed, we can answer this question actually on the upcoming, it's going to be just a panel session on global health and its AI, ethics of AI in global health, less presentations and just sort of interactive sessions. If I can at least hold off answering that question right now, we will answer it for sure in the next session. Yeah. And then there is a question from anonymous attendee how do we avoid the hype factor that comes with the potential disruptive technology such as AI? How do we separate the wheat from the chaff in research and products? And I mean, I can take that one. One thing is that I think capacity building. So my focus actually in research, doubling as a radiologist, is really to test how AI fails. So I spend a lot of time testing models and testing, how they fail. But there are things that we can do sort of generally, like curating data sets that can be in the public domain or available for people to validate their models on. And so that way, the more you test the AI systems on new data sets, the better it becomes and the more we learn about how it fails. So for example, for this COVID period, we have 1,600 chest x-rays from Emory, from patients who were COVID positive, that we are curating and allowing anyone who wants to test to bring the algorithm in and test the performance, and we can give them the results. And so this idea of sort of curating data sets and building these building blocks, and also the personnel to be able to run and understand how these algorithms work will be super important. Jessica, I'm going to pass your question on to Dr. Langren about photography. I think it's a fantastic question. But at this point, respective of everyone's time, I'm just going to have Dan go for 30 seconds and say what's exciting him right now or what he's looking forward to, and Murad, and then we'll end the panel.
Well, thanks, Judy. And again, I'm looking forward most to your next panel, Judy, in June, when we discuss a very concentrated discussion on the ethics of global health AI, because I didn't have time to get into it here, but the ethical issues, data privacy, confidentiality, and I showed in some slides just how complex some of those data flows can be. And I think we're going to have a great discussion in June about that, because I think that's the thing that we really need to conquer next, is how do we make sure that we can deploy AI in a way that's ethically sound and really helps these hospitals to, deploy it in a way that takes care of patients. So.
Murad, some final words?
Yeah, thanks, Judy. So I think it's coming from African countries. So I think in the near future, I hope to see like these AI technologies are, I mean, around developing world. So I think it's the best way is to all the countries, I mean, benefits from these technologies. I want to see more training to medical doctors in these countries, to AI scientists. It's great to have schools, I mean, bring people from the Western world to train students, to encourage them. Something very important as well is this scholarship. So there are some countries that they help students from developing countries like yes, Canada and some European countries to give scholarship. And also something very important, I am looking for these minds that they are, I mean, African minds, for example, they at least they come back to their home countries and try to help the local community to get in these technologies. Yeah. Thank you.
Awesome. Well, at this point, what's exciting me most is the upcoming SIIM meeting. It's usually a fantastic time to meet friends, and because of COVID, we will be meeting friends on Zoom. But it's a really good way to get involved. The registration has been dramatically reduced as a part of, COVID celebration, sort of like celebrating the people who are working in the back end to keep the front line strong to take care of the pandemic. And so I hope to see a few people there, and please join our global health ethics panel. It was very fantastic last year, lots of questions, and hopefully we'll be seeing some of you. Thank you so much for spending the time with us, and have a good rest of the day or evening. I hope no one is in the morning yet, but bye-bye.
Thank you, everyone. Bye-bye now.
Bye-bye.